Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Hello, I'm Tony Urbina, the Medical Director for CEI's HIV Primary Care and Prevention Center of Excellence. I'm a provider and professor of medicine at the Icahn School of Medicine at Mount Sinai, who has worked in HIV and LGBTQ health for over 20 years. In today's podcast, I'll be talking with geriatrician Dr. Angela Condo about the unique clinical needs of patients aging with HIV. Dr. Angela Condo is a board-certified internist and geriatrician. She completed her internal medicine training in primary care at Weill Cornell, New York Presbyterian Hospital, and subsequently finished a 2-year geriatric fellowship at Mount Sinai Icahn School of Medicine. Dr. Condo currently serves as assistant professor of geriatrics at Mount Sinai, where she manages an outpatient primary care geriatric panel at Mount Sinai downtown Union Square. In addition to her clinical work, she teaches medical students, internal medicine residents, and supervises geriatric fellows. With grant support from the Keith Haring Foundation, she established the comprehensive program of integrated care for older adults with HIV at Mount Sinai's Peter Krueger Clinic. Additional HRSA funding through the SPIN's Aging with HIV initiative enabled the addition of a community health worker for the team. The program adopts an interdisciplinary approach to caring for older adults with HIV. Dr. Angela Condo enjoys the complexity in caring for older patients and the teamwork required to do it successfully. Welcome, Dr. Condo. Thank you for joining us today. So let's start off by, if you could tell us a little bit about your program.
Of course. Thank you for inviting me to speak with you today. I'm happy to be here. And I'd love to share a little bit about our program of comprehensive care for older adults with HIV at Mount Sinai. So our program started back in 2020 with grant support from the Keith Haring Foundation. At that time, members from both the geriatrics and the infectious disease departments acknowledged the aging population of people living with HIV and really brainstormed how to incorporate geriatrics into HIV care. And what we decided to do was bring geriatrics into the HIV clinic. Our interdisciplinary team included myself as a geriatrician, a clinical pharmacist who we newly hired, a nurse from the HIV clinic, and a social worker from the HIV clinic. And we really thought it was important to include members from both geriatrics department and the infectious disease department on our team so that patients felt comfortable meeting a new group of people. This is really a multidisciplinary clinic model where our geriatric team is embedded in the HIV clinic 1 day a week. We serve as consultants to the HIV primary care provider, so patients are referred to us for a specific reason, usually for 5 reasons that coincide with the 5M framework of geriatric medicine. So those are multi-complexity or just multiple active or uncontrolled medical conditions, for mental health or cognitive concerns, for mobility or balance issues, for medications or polypharmacy, and then the 5th M of what matters most, have advanced care planning discussions. We do many different screenings related to all of these issues, including falls screening, cognitive screens, a screening for loneliness, and also frailty screenings. The majority of patients really do come for cognitive-related issues, and we spend, a full hour going over cognitive concerns and do some of these other additional screens as well. And because patients come with multiple conditions and often complex issues, we do monitor their progression over time. And so patients usually come back to see us every 3 to 6 months for consultation.
Yeah. I love this kind of multidisciplinary approach. And I love how it all just kind of came together. So for how many years now had this been up and running?
So it's been 5 years.
Wow.
It'll be 5 years this September.
Okay.
Yeah.
Very, very interesting. So kind of based on that experience and what you've said so far, I think so just to unpack some of the kind of conditions that patients get referred to. So I think one that you mentioned was like HIV-associated frailty. So we know patients living with HIV develop like these age-related weakness, fatigue, and this physical decline, but like earlier than expected. What's kind of been your approach to that?
Yeah, so frailty is really common geriatric syndrome. And like you mentioned, it's this physiologic decline of weakness, muscle wasting, so exhaustion. And it's associated with increased vulnerability to disease and really adverse health outcomes like falls, functional decline, hospitalization, even mortality. And like you mentioned, older adults with HIV are more likely to experience frailty at younger ages compared to adults without HIV. Some studies, they show the prevalence of frailty and pre-frailty in adults with HIV age 50 and older to be 10.9% for frailty and then 47% for pre-frailty. So pretty high prevalence of frailty and pre-frailty in this population. We screen using what's called a frail screen. There are many different screening tools for frailty. Some of them are pretty cumbersome and more so used in research studies. So the frail screen that we felt was very practical to use in a clinical setting. It consists of 5 questions that we ask patients. And so that those questions are, have you felt fatigued most or all of the time over the past month? Do you have difficulty climbing a flight of stairs unassisted? And do you have difficulty walking 1 block without any assistance? Do you have 5 or more illnesses? And there are specific illnesses that are listed in this question. And then the last question about weight loss, have you lost more than 5% of your weight in the past year? And an answer to yes to any one of these questions is given 1 point, and a score of 3 to 5 is considered frail. A score of 1 to 2 is considered pre-frail, and then 0 is sort of robust. No evidence of frailty or pre-frailty. Because frailty is potentially reversible, like it is important that we're screening for this, and also it is so prevalent in this population. The management strategies are really behavioral. So I think this is the big challenge. Management strategies are really that comprehensive geriatric assessment. So not just the patient's medical comorbidities, but sort of their psychosocial functioning, their environment. How can we support them in their environment to improve in these certain areas? Really focusing on modifiable factors like nutrition and physical activity. I know one of the sites at Sinai is fortunate to have a nutritionist site. Not all of the sites do. Finding a nutritionist for patients, that can be difficult with patients' insurance carriers as well. I start the nutrition conversation, but there's often not enough time to go in depth into sort of a full nutrition discussion. So we do try to connect patients to resources if they're interested in that. And physical activity, we refer patients very often for physical therapy, whether that's at Mount Sinai itself, for physical therapy at home if they're really having mobility challenges, or at a location in their community that's most convenient for them.
Yeah, great. So just kind of shifting a little bit and you spoke a little bit about cognitive health. So we know HIV has significant impacts on cognitive health, like even in the modern HIV era, we've heard about this HIV-associated neurocognitive disorder or HAND, and it still affects a lot of people with HIV, even those with undetectable viral loads. So what's kind of been your approach to cognitive health in our older patients?
Cognitive health is a huge topic. We could spend an hour talking about cognitive health in itself. HIV-associated neurocognitive disorder, or HAND, is still prevalent today. The prevalence of HAND actually hasn't changed from the start of the AIDS epidemic, but the severity of HAND is a spectrum, right? So the severity has changed over time as HIV is now usually well controlled with an undetectable viral load. Patients often have asymptomatic neurocognitive impairment, or that ANI stage of HIV-associated neurocognitive disorder. And what we're also seeing now is patients with HIV are developing other neurocognitive disorders like Alzheimer's dementia, or Parkinson's and Parkinson's-associated dementia, and Lewy body dementias. So the evaluation is really trying to figure that out, what exactly is going on, what is the cause of their cognitive decline. Some people feel, why is it important to distinguish between the cause? Because there's not great medicines, and if you're treating HAND, you're treating the HIV itself and making sure the viral load is controlled, which you're doing anyway. But I think there are some people, and myself included, that think it is important to help distinguish because we know the courses of these diseases are different, right? So HAND tends to have a more fluctuating course, whereas Alzheimer's dementia tends to have a slowly progressive course that's worsening over time, where somebody's with Lewy body tends to progress more rapidly. So really, the importance of helping distinguish among these different disorders is to counsel patients on what to expect for the future and help them in their advanced care planning. But so that aside, the evaluation really starts by asking patients about their concerns. Do they have any concerns about their memory? Have they noticed any changes in their memory? If so, I really try to ask them to explain more. Do they have like specific examples of things that have happened that led to these concerns? And it's more than just memory, right? Your cognition is complete of multiple different cognitive domains. So I really try to assess that when I'm assessing someone's cognition. For instance, are there troubles with language? Are there attention deficits? Can they concentrate? Are there visual spatial problems? Are they having trouble navigating their environment on their own? And so we're asking all of these different questions and really trying to decide if there's anything modifiable going on that we can fix that might improve cognition. And honestly, this is most of the patients that I see. There's so many different modifiable factors. These are things like poor sleep, hearing impairment, a mental health disorder, so uncontrolled depression, anxiety, stress, polypharmacy, specifically medications that have a high anticholinergic burden, inactivity, substance use, loneliness, and then uncontrolled vascular risk factors. So whether that's uncontrolled HIV, uncontrolled hypertension, diabetes, high cholesterol, all of these things we can improve on that might help cognition in the long term. We also discuss what's probably most important is like how their cognition is affecting their functioning. Are patients able to complete their activities of daily living by themselves? These are things like, bathing, getting dressed, and also their instrumental activities of daily living, those more complex tasks like managing medications and finances. And our community health worker actually does this initial screen for patients' functional status. And I always ask, I'm like, okay, they can't manage their medications, but why is that? Is that because they're having memory issues and they're forgetting to take their medicines, or they have bad osteoarthritis of their hands and they can't open the medication bottles by themselves, right? So it's really important to distinguish why they're having difficulties day to day. The other thing I really always ask about is whether or not I can talk to a family member or a friend about to get their perspective on the patient's cognition and if they've noticed a change over time. Not everyone allows this, but it is really important when you can to get collateral from others when assessing memory complaints. And so if there's not a family or friend available, I'll often reach out to the primary doctor or the social worker who's maybe known the patient for a longer period of time to get a sense of what changes they've noticed. And so after all of that history, we then do the cognitive test. My cognitive screening test of choice is the MoCA or Montreal Cognitive Assessment. That takes about 10 to 15 minutes to administer in the office. And then after that, a full neurological exam, including a gait assessment. Again, thinking about your differential diagnosis. Do they have a wide-based unstable gait and you found out they have urinary incontinence and now you're concerned, oh no, is there some normal pressure hydrocephalus going on that might be contributing? So all of this information we take into account to figure out what the differential diagnosis might be. And then the workup usually includes some type of neuroimaging, which is a CAT scan or a brain MRI. We often obtain labs for other reversible things like thyroid dysfunction, vitamin B12 or folic acid deficiency, and syphilis infection, which if abnormal can affect memory. And so after putting all of this stuff together, you usually have patients come back after they get their brain imaging and we talk about what might be the diagnosis. Many of the patients that I see have an abnormal cognitive screen, so have an abnormal MoCA score, but are still functioning pretty independently. And so most patients we talk about then, that is considered a diagnosis of mild cognitive impairment and what might be contributing. Again, we review all of those reversible things like sleep and anxiety and polypharmacy. And so the management plan is really mostly non-pharmacologic. And the best way, I always tell patients, the best way to maintain your brain health is to be mentally and physically active. And we talk about how that might make sense for the patient. And then I always often say, whatever is good for your heart is good for your brain. And patients tend to understand that.
Yeah, I like that. That's quite a comprehensive approach. And I like that you kind of, focus on the things that can be modifiable and that can maybe mitigate some of these effects. Because oftentimes I think we're just like, oh, aging is just inevitable and these things are going to happen. So I kind of really like that systematic approach. Now, you did speak about, polypharmacy and that you have a pharmacist on your team. You want to talk about some of the unique polypharmacy challenges in geriatric care in this population?
Yeah, definitely. I think the big challenge is there's no real definition of polypharmacy. It's there's no consensus. So some people define polypharmacy as 5 or more medications other than antiretroviral therapy. Other studies consider it 5 or more medications, including antiretroviral therapy. So there's that controversy out there. But it's a huge problem in adults with HIV. Polypharmacy, not surprisingly, increases with age. It increases with duration of HIV and then comorbidity burden. So if certain studies looking at adults, specifically 50 and older with HIV, up to 90% of people experience polypharmacy. And that's certainly like the range that I see in my clinical practice. So when you have 5 or more medications, it's tough to manage. And the fear with that is it leads to non-adherence. And what we see, though, actually is it's not non-adherence to HIV medications. Most of these patients are actually doing a great job taking their HIV medications every day. A lot of patients are on a single drug regimen. And so that's not the problem. It's like they're 4 times a day insulin injection between their long-acting and their short-acting insulin, or their, beta blocker that's twice a day. It's those medications that patients we found have more trouble with adherence because the regimens are complex, and I think the other thing that makes the medication regimens complex is absorption issues. And this is something our pharmacist often identifies that I probably wouldn't pick up on if I were doing this by myself. But that's why it's so nice to have a pharmacist on the clinical team, because he really goes through and they go, well, you're on the calcium and you're on the iron. Make sure you don't take that with your antiretroviral medication or other, drug-drug interactions that can affect absorption. So it's really nice that he identifies that. But then those regimens become more complex for patients, and that can lead to non-adherence. He's often identified drug-drug interactions, category D or higher, that need to be monitored over time. And then also interactions with liver or kidney dysfunction, making sure medications are dosed appropriately. With age, kidney function naturally declines with age. And so we need to just be aware that medications are dosed appropriately. And then I mentioned this before in talking about cognition, the anticholinergic burden of patients' medication. So this is important. And our clinical pharmacist will calculate like a total anticholinergic burden score. And you can look up these calculators online. You put in a patient's meds and it gives you a score back. But essentially a score of 3 or higher is associated with increased risk of cognitive impairment and even mortality. And other anticholinergic side effects include dry mouth, confusion, dizziness, and falls. So it can affect, other symptoms that patients are often experiencing, that older adults are often experiencing, other than just cognition. So I think I'm so lucky to have the clinical pharmacist on our team who's really reviewing in detail the patient's medications. And I think also educating patients. It's so hard in I know because I do geriatric primary care as well. So I know how hard it is in primary care to address everything during your visit. There's just not enough time. So making sure that patient sits with the pharmacist, goes through their medications, and understands why they're taking their medications and for what indication is so important.
Yeah, great. Those are really, really important aspects. And I think it's just great that you have this comprehensive team that can just kind of guide us and help us to maximize, our patients' health. So I think you also mentioned that you have a social worker on your team.
Yes.
Yeah. So you want to talk about, because I think we often see patients that are, living alone or sometimes even homeless or, food insecurity and things like that. So how does your team kind of handle or navigate these kind of social determinants of health? And maybe you can list the ones that you see are most kind of prevalent.
Yeah, definitely. I think the biggest thing we do to address this is really talk to patients about what matters most. And that often comes up when you ask patients what matters most, because if they're not, able to afford 3 meals a day, right, they're probably not going to be so excited when you tell them, oh, you need to eat healthier when, they can't even afford their 3 meals a day. Really, asking patients what matters most is so important and usually brings out a lot of these conversations and topics. So sometimes patients are like, oh, my housing situation is really bad. And I don't feel safe. And so that comes up as conversation as most important to them. When I tell them, oh, you should go out, go for a walk. And the patient's, well, I live in a bad area and I don't really feel safe going out with my cane. I look vulnerable. I know it's happened to other people, then, I think opening up the conversation allows us to understand how that patient is living day to day, outside of our medical office visit. And then we connect that patient to the social worker, to the community health worker to see, what support can we provide? We can't always fix the situation, but we try our best to develop creative solutions to help that patient feel safer and age well in their community. We also screen for loneliness, and it is a huge problem in older adults, specifically older adults with HIV. A lot of our patients that we see are living alone. We use the UCLA 3-item loneliness scale, very simple questionnaire that our community health worker asks. And I think, the big benefit of our interdisciplinary team is that we can each use our time and our talents to help patients. And these conversations just come up naturally, which I think is really nice. We have a pretty diverse team as well, which, allows patients maybe to feel comfortable with one person where they might not as feel comfortable sharing these intimate issues with other patients. And like you mentioned, we do have a social worker. So she's available to sort of complete like a full psychosocial assessment for patients who maybe are not currently working with a social worker or have new needs that arise during our visit. And our community health worker will help patients find resources in the community. We're also working, because loneliness is such a problem, we're working on developing relationships with community partners to provide some resources for patients. One community organization called Senior Planet, we've been working with to sort of introduce patients, one, to their center, but also maybe have some group classes where we bring a group of our patients to Senior Planet. Patients, when they go there, they can learn multiple different sort of like tech kind of topics. How do I use my MyChart account? How do I set up an Instagram? Things like that. And so it's a nice way for patients to socialize, engage in community in something other than a senior center, right? That might have some stigma associated with aging. Or, a 53-year-old I'm not that old. I don't belong in a senior center. So really trying to develop resources in the community where patients feel comfortable going, being with others, engaging in socialization, maybe learning something new, which it would be for their brain health as well. I think in all, like addressing social determinants of health really just requires like a holistic patient-centered approach, which is what geriatrics really is. So I think it goes hand in hand with the geriatric approach. These things don't often come up on a first visit, right? Because it requires trust, a trusting relationship, and that develops over time. And that's when these more difficult conversations come up about loneliness, about stigma, discrimination, social isolation, these things that patients may not share on a first visit, but also, again, why we have patients come back and see them over time.
Fantastic. This is such a unique model of care for integrating geriatric care and HIV. I think my final question to you, could you kind of look into the future for HIV care for older adults? And I think you mentioned that you had some initial funding. You want to talk about what that kind of looks like in this new environment that we're all kind of dealing with? What are your thoughts about that?
Yeah. Do I have to? No, I'm happy to share. So I think I'm biased because I'm a geriatrician, but the future of HIV care is geriatric care. And we all know this, like over 50% of people living with HIV are over the age of 50. By 2030, it's going to be 70%. So people are going to be aging with HIV. And as it is now, right, HIV care extends beyond viral suppression, and it's addressing all of these geriatric syndromes and comorbidities. I'm hoping there will be more integrated care models like ours, but there aren't many of us geriatricians out there. So honestly, I think over time that primary care for adults with HIV is going to shift more towards internal medicine providers and geriatricians when available. And I think ID docs are going to be serving more in a consultative role, really helping monitor and manage the antiretroviral therapy. But honestly, for most patients that I see, that is controlled. They take their medications, they have their viral load checked every 6 months, and that's not their major problem. That's not what matters most to them at this point. It's their functional decline and other geriatric issues. So that's sort of where I see the clinical care moving. I do think we need to try to do our best to help patients age well in the community. That's what most people want. But I also think we need to prepare to care for older adults in other settings. And those are settings like assisted living facilities and long-term care facilities. Because like you mentioned, many patients live alone. Their social networks have thinned over time, and many of them don't have family or friends to help care for them as they're aging. And so I think we're going to see more adults aging with HIV looking for alternative care sites. And so we need to sort of prepare for that now, because I think we'll see that in the next 10 years or so. As you mentioned, the funding issues, it's real. An interdisciplinary care model like ours is not easy to run from a financial perspective. We have a lot of team members who don't bring in revenue. They don't bill. And the geriatrician's billing just doesn't bring enough revenue to support every team member's salary. We are so fortunate to have grant funding and continued grant funding over these past 5 years. We continue to try to show the value to the system, what value we're bringing in as a geriatric team. Can we prevent hospitalizations? Can we prevent ER visits? That's tough when you're not managing their primary care and you're serving in a consultant role. But we've been working with the quality team in the infectious disease department, and I'm taking on some patients who are in value-based payment plans, who are 50 and older and have uncontrolled comorbidities, so uncontrolled hypertension, uncontrolled diabetes. Can we help them with those chronic conditions? Which, some might say, oh, that's not a geriatric issue, but we know that uncontrolled hypertension, uncontrolled diabetes can contribute to cognitive impairment. They're all connected. And so if we can help these patients improve on these comorbidities and then help them prevent some geriatric syndromes, that would be great. And so we're, trying to see if we can make an impact here. And then this would show some financial value to the system. Always thinking about creative ways to show the healthcare system the value that we bring. And I think also thinking about, what resources, if you're another site trying to think of how to incorporate geriatric care, do you have a nurse that's really interested in sort of the geriatric approach, and can she be trained or he or she be trained to do some initial geriatric screens? Or can you partner with a pharmacy school? So that way there's a trainer then that you're sort of teaching, but they're also helping you, and you're not obviously paying them as a trainee. So all of these other sort of creative ways to think about how to implement a team in a financially sort of responsible way.
Well, Angela, thank you so much. We just want to thank you, just for being kind of at the, the ground floor of building such an amazing program. I think you've really created like a really unique space where like science meets humanity. And that, hey, there are things that you can do to really live and age well with HIV. So again, thank you for sharing all this about your program, and we wish you continued success.
Thank you so much. And I really love that science and humanity statement. You just summed up why I went into medicine. So I really appreciate you for saying that.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.